Okay, so thank you everyone for joining in and joining in on time. Today's topic is on anemia during pregnancy, and our expert speaker for the evening is Dr. NJOROGE. Dr. NJOROGE is a consultant obstetrician gynecologist at Embu Level 5 Hospital in Embu County. She trained her MED at University of Nairobi, and she has a vast experience working with the government. She has several research papers published on PPH, unicornate uterus, etc. And she's passionate about improving quality of obstetric care. So welcome, Dr. NJOROGE. We are glad to hear from you.
Oh, thank you, Winnie, for that nice introduction. Good evening, everyone. Thank you for having me, essentially, for this interesting topic. It's going to be quite short. Yeah, Enoch, so we can proceed?
Yes, we can. You may share your screen. Let me see. Are you able to?
No.
Okay. You should be able to now.
No, disabled.
And now? It says you're the host. Sorry.
Yeah, okay. Okay. So as I said, it's quite a short, it's a wide topic, but we'll make it quite short and to the point. Anemia in pregnancy, I'm sure most of us, if not all of us, have managed a patient or interacted with a patient who had anemia in pregnancy, if we ourselves have not suffered from the same. As Dr. Winnie had said, my name is Dr. NJOROGE. I'm an OBGYN at Embu Level 5 facility. So this is the outline of the talk for the day. We're just going to go through the background, the definition, the pathophysiology and causes, signs and symptoms, management, and eventually we'll just go through a short case report. So the background, what is anemia and why is it such a big deal, and why is it featuring in these 12 topics that we have picked to discuss? One is the commonest medical condition in pregnancy, and globally affects about 58.2 million who are pregnant. Majority of those, around 96%, are from the developing countries. The Kenyan figure stands anywhere between 20 and 70, depending on which studies you're reading and which counties you're in. I sampled some of the studies. Ndohio et al. In Bagati had found it to be at 36%. Okubatsi in Pumwani found it to be 57%. Somebody had found that in Kakamega to be 40%. In Kisumu is higher. Nutritional anemia, predominantly iron deficiency anemia, is the commonest. It is an important contributor to maternal and perinatal morbidity, and is an indirect cause, causing about 20% of it. So to define what anemia in pregnancy is having a hemoglobin level of less than 11 or hematocrit of less than 33%. So it's graded. So there's mild anemia, which starts with a HB of 9 to 10.9 grams per deciliter. Moderate anemia, which is 7 to 8.9. And severe anemia is when you consider a patient has less than 5 grams per deciliter of HB. So just to take us back a little bit and remind ourselves of the physiological changes that occur in pregnancy. One is that the plasma volume expands by 50%. So which peaks at around 34 weeks, 33, 34 weeks. But the RBC mass only expands, red cell mass only expands by 25%. So that sort of results in a nutritional and a physiological anemia, we call it, like hemodilution. So it's like an apparent anemia. So there is a low HB, low hematocrit, and the RBC count is low, but there's no change in MCV and MCH. There's also a 2 to 3-fold increase in iron requirement in pregnancy and a 10 to 20-fold increase in folate requirements. This is just a graphical representation of what we are talking about. So the plasma volume would expand, and this is at 34, by 34 weeks, it's around 50%, but the red cell mass only increases by 25%. So the reason there's such a high demand for iron and folates and some of the micronutrients is due to the increase in the red cell mass, which is erythropoiesis, basically the formation of the red blood cells. And this requires proteins, which for the synthesis of the globin, just to remind us all who have forgotten the physiology, the minerals required, you require iron for the synthesis of heme. You require hormones such as erythropoietin from the kidneys to stimulate the bone marrow, thyroxine, androgens. You also require trace elements such as zinc, cobalt, copper, and the vitamins that are vital for erythropoiesis, which is formation of the red blood cells, are vitamin B12, folic acid, vitamin C is quite key for conversion of the folic acid to folinic acid, and for enhancing the absorption of iron from the small intestine. Pyridoxine is also quite useful, and vitamin A is vital. That just takes us back. So the commonest type of anemias in pregnancy, as I'd say, there are different types. And just because one is pregnant, they are not exempt from the anemia that can happen to any one of us. So, but the commonest ones in pregnancy that we encounter are the nutritional deficiency anemias, predominantly iron deficiency, as we had said, which accounts for 90%, more than 90% actually, of all the cases in pregnancy. Folate deficiency as well, and vitamin B12 deficiency. These form the bulk of most of the anemias we will manage. There are also the hemoglobinopathies. For our population, the most common one would be a sickle cell disease. And we have the anemia, there's one that's missing. There's anemia of the chronic disease. And then, of course, you have the rare types that the autoimmune, hemolytic, the leukemia, they are plastic anemias. So let's go straight to iron deficiency, because that is what we encounter and manage majority of the time. As we had said, the red cell mass increases quite significantly during pregnancy, and as well there's a demand for iron. So where does all this iron go to? One, iron in total, you need extra 1,000 milligrams from beginning to the end of pregnancy. And this is subdivided into the following. So for the fetus and the placenta, it takes about 500 milligrams. For the red cell increment, another 500 milligrams. Postpartum loss, you expect to lose about 180, and this is for normal delivery. This is where the patient does not develop postpartum hemorrhage. For lactation, up to 6 months is 180. If you extend it further, then you double that number. So you can see there, the requirement is actually higher than that. However, because of the subinvolution of the uterus, and as well as you get the lactational amenorrhea, and there's no loss of the monthly blood loss through menses, there's also conservation of around 350 milligrams. So the actual demand is 1,000. Considering you have, when the stores are full, we consider it to be 1,000 as well. So how does iron deficiency anemia occur? One, it is when you're starting with a negative. So there's already depleted stores. This can be due to poor nutrition. People of poor, low socioeconomic status might not be getting their proper dietary requirements, chronic illnesses, lack of deworming, a patient who has chronic menorrhagia that's never been corrected, or the anemia has never been corrected. Again, as I said, chronic infections and diseases, repeated pregnancy. There's a saying, obstetricians like, it's too many, too fast. So one after the other, eventually you'll deplete the iron stores. Of course, multiple gestation, when you're talking about twins, triplets, and so on and so forth, you're going to require more. It can also happen in acute blood loss, such as in acute a patient who has APH or early pregnancy bleeding, or even the one that's unrelated to the pregnancy, such as the GI bleeds and so on. We know the high-risk women are the adolescents, the multiparous, multiple pregnancy, and women from the lower socioeconomic status. So this is one of the reasons why anemia is such a big deal. So the effects in pregnancy is that you might end up with a high output cardiac failure due to the lack of the low oxygenation. So you end up with a high output failure. There's also an increased chance of getting PPH, subinvolution of the uterus. It does predispose to infections. So piperosepsis, endometritis in postpartum. There's a high risk of thromboembolism and PTE. There's just generalized delay in recovery. As for the fetus, the reason we worry about that is because iron is required for the developing fetus, for even formation of the muscles, formation of the brain. So you might end up with preterm birth, intravenous growth retardation, and subsequently low birth weight. They can get an anemic fetus, an anemic newborn, and delayed cognitive function. I think this one is key. This is why it's a public health issue. If you have delayed cognitive function, then you have a child who is a poor learner. A poor learner ends up being an adult who is not productive. So then you have a less productive nation over something that could have been easily prevented. So the clinical presentation for this is just, I'm mentioning it as for iron deficiency anemia, but it applies to all the anemias. It depends on the severity of the anemia. So if you have a mildly anemic patient, she might not even know she's anemic. She might be just asymptomatic. But when the symptoms occur, they can include weakness, pallor, fatigue, palpitations. They may complain of lower limb swelling or just generalized swelling, depending on the severity of the anemia. They might complain of having chest pain, difficulty breathing, and so on. So how do you work up a patient who has presented to you with anemia? One, of course, is to take a very detailed history. You need to know her age, her parity. You need to take a proper dietary history. What does she consume? How often, how frequent? What is the variability in her diet? Does she have any history of chronic bleeding, like chronic ulcers, hemorrhoids, and so on and so forth? Has she been dewormed? Is she from a malaria endemic? Has she traveled? Malaria endemic region, has she traveled? Those are sort of the questions you would want to inquire. On examination, you're looking for pallor, you're looking for jaundice, you're looking for edema. You can notice a beefy red tongue, which you call glossitis or stomatitis. In case of hemolytic anemias, you might find a hepatosplenomegaly. You can also find purpura if the patient has a bleeding disorder. You might also find evidence of chronic disease that can also lead to anemia, such as renal disease or TB, and of course, signs of cardiac failure in severe cases. So the investigations you would start off with is a simple, for those who are just in the sub-counties or in the dispensaries, a simple HB will let you know that you have a low hemoglobin and you might need to investigate this patient further if you can. But a full hemogram will give you the red cell indices that you are interested in, and that will sort of put you in the right direction, whether you're dealing with an iron deficiency anemia, folate deficiency, or any other type of anemia. So when it comes to the iron deficiency anemia, the HB, of course, is low. The hematocrit is also low. All the red cell indices are also low. If you do a peripheral blood film, you are expected to find a microcytic hypochromic anemia. That's the technical term. If you want to further investigate, this might not be necessary in all the cases. You can actually check the serum iron, which would be decreased in iron deficiency. You can check the total iron binding capacity, serum ferritin. You can do a bone marrow examination, depending on what guides your investigations more so is what you find on the examination and from your history. What could be leading to this level of anemia? So that is what will guide your examination. But the basic ones are basic. The hemogram should be able to tell you the sort of anemia you're dealing with. You can check your stool for ova and cyst, and for occult blood in case the patient has not been dewormed. Others include endoscopy if you're looking for GI bleeds, or chest x-ray if you're suspecting a chronic illness like TB. So how do we manage iron deficiency anemia? The primary thing is to prevent. Prevention before cure. So when you're talking about prevention, this we cannot talk about without talking about preconception care. As we are removing that IUD and as you're removing that implant, we are asking this patient if she wants to conceive, if that is her plan. Do we think about checking her HB or starting her on hematinics or folate? Of course, another one is to start early ANC as soon as possible, so that we identify the ones who are at risk. And 2, you can start your supplementation very early. And 3, you can catch them if it's anemia early enough, you have enough time to correct it over time. Folic and folate supplementation, which is a government policy commonly known as IFAS in our country. Child spacing, of course, we sing about this, and this is the reason why. And again, I repeat, too many too fast, you will deplete the iron stores. Of course, deworming, malaria prophylaxis, and dietary counseling. I am sure we have all encountered this because they are all in our guidelines and it's part of our national program. So for treatment, the objective is you want to normalize the hemoglobin levels before delivery. And 2, you want to replenish the iron stores. So how you correct that for the anemic patient is the route of administration will depend on the medication that you choose to use. Will depend, 1, on the severity of the anemia, 2, the gestation of the patient, 3, compliance, and 4, how well compliance and how well the patient is able to tolerate whatever formulation you're giving her. So that's where we're going to start. So for mild to moderate, we start with the diet, and this applies to even the ones who are not anemic, just generally any patient that you're dealing with. And you're thinking they might be a high candidate for increased iron demands. So 1 is what is in the diet. What do you advise your clients? I want actually participants on this one. No, can I see who is here? Wamoshi. If I can call you out.
Yes, Daktari.
Yes. So what do we advise our clients on vitamins, iron diet, iron-rich diet?
I think the best would be animal protein. If it is affordable and available. But that does not mean they cannot use veggies and others. So that we don't block out people who say I cannot afford this.
Any other contribution? Because I find this to be quite an interesting thing. We don't, I feel, in my opinion, we don't give our clients the correct advice and the correct things to do. So iron is a very, what can I say? It's a mineral that's it's difficult to absorb. The best type of iron that is most bioavailable is the heme, as Mamosha had said, that's found in animal protein. So that one you'll find it is absorbed at around 5 to 10% of once it is ingestion. But for the ones that are from the vegetable sources or the legumes and whatnot, you get an absorption rate of about 1 to 2. So there are foods that enhance absorption of iron, which include the vitamin C and some, what are they called? I forgot the names, glycine as well. And there are foods that will inhibit iron absorption, such as tea, the tannins, tea, coffee, of course, calcium, phytates, phosphates, clay and rocks for those who have pica will interfere. For the phosphates, for the phytates, it's found in cereals. So you can find that a patient is eating her chapati and her madondo with her beans and a very milky cup of tea and taking her iron supplement at the same time. You can rest assured that will not give you, as you're trying to correct your anemia, it will take you forever and you keep asking yourself why you're not getting any progress. Also, the medications that we give. We know in pregnancy, it is common to have heartburn, or a bit of gastritis, a bit of irritation. So we prescribe them PPIs and antacids, and also don't give the correct advice and say, you might want to take the iron on an empty stomach, or separate the time between you're taking your antacids and your PPIs for at least 2 hours. As we supplement with them with calcium, make sure you're giving the correct instructions so that she's able to fully utilize the iron that she's ingesting. So the oral preparations that are available, I think all of these are available in the market. There's the fumarate, iron fumarate, iron ferrosulfate, which is the one used in the government facilities, gluconate. There are so many. I think the ranferon is fumarate, the others I can't remember, but there are quite a few. Each provides a different dosage of elemental iron, fumarate being the highest. Fumarate is considered to be the most friendly to the GI system with less side effects. So we expect therapeutic results of about 0.5, sorry, that's 0.5, not 5, 0.5 to 0.8 milligrams per deciliter per week with good compliance. And when we have given our patients the correct instructions on how to use the iron. 2, for severe cases, you can consider parenteral iron. I think the one that is available to us should be iron sucrose, which is Venofer. Yeah, I'm sure all of us have used Venofer here or there. There's a formula that's used to calculate. I'll share on the WhatsApp group later. Venofer will give you an increase of around 1 gram per deciliter per week. So another one is transfusion. And the indications would be severe anemia fasting in the 3rd trimester when there's no time to correct or no time to get to the appropriate HB. Anemia due to acute blood loss and the patient is symptomatic, such as APH and GI bleeds, upper GI bleeds. Patients not responding to oral or parenteral therapy or unable to tolerate it. So those ones can also benefit from a transfusion. Anemic and symptomatic women who are with heart failure, they are symptomatic enough to lead to heart failure, then irrespective of the gestational age, you need to correct that anemia. Another addition is for parenteral iron. It also comes in handy when for patients who object to transfusion due to religious reasons. Yes. So remember the side effects of oral therapy is GI upset, constipation, diarrhea, the metallic taste, the black stools. For parenteral is anaphylaxis being the most serious one. You can get a local abscess, skin discoloration, or an iron overload. So that's it for the iron deficiency anemia. We'll just quickly move on to the iron deficiency, to the folate and vitamin B12 deficiency. It also compromises significant in our population. So it complicates up to 1% of pregnancies, and it is characterized by RBCs of high MCV. The white blood cells have an altered morphology as well. It is usually caused by the folate and B12 deficiency. So for the folate deficiency, these ones are women who are taking anticonvulsants in multiple pregnancy, hemolytic anemia, particularly with the sicklers. The maternal risk, of course, as I said, is megaloblastic anemia, and the fetal risk is preconception deficiency can cause neurotube defects. The diagnosis, of course, is an increased MCV of 100 femtoliters, and a peripheral smear will show you a macrocytosis. You can also do your serum, folate, or RBC folate. Okay. So for the folate deficiency anemia, the daily requirement for non-pregnant women is around 50 to 100 micrograms, which they can easily get from the diet. For pregnant women, that increases by about 10 to 20 to 300 to 400 micrograms. Usually it's present in fruits and vegetables, but is destroyed by cooking. So for folate deficiency, you want to supplement 0.5 to 1 milligram of folic acid per day. For patients with a history of neurotube defect in a previous pregnancy, it's 4 milligrams of folic per day. However, I know in our IFAS, it is 5 milligrams, so we are over that. Vitamin B12 is rare, but it occurs in patients who've had history in the upper GI or patients who have pernicious anemia, and so on and so on. So it's a megaloblastic anemia, basically. Treatment is, of course, by administering B12, 1 milligram IM weekly for 6 weeks, if you come across it. So how do we manage this patient during labor? It depends on the condition of the patient. So of course they should be, if a patient is severely anemic, then you should be on an alert. They can quickly decompensate as they deliver. Okay, so they should be in a comfortable position with adequate analgesia, oxygen for those who need it, of course, strict aseptic technique. You should have a low threshold for assisted delivery. Of course, we avoid the ergometry. Prophylactic antibiotics are recommended for patients who are anemic. And then we have to continue with the iron and folic therapy for 3 to 6 months, depending on the level of the anemia, and appropriate contraceptive advice and child spacing. So that was it. So we'll quickly move on to our, I told you this was a short presentation. We'll quickly move on to our case, which I want to be open to discussion. This is a patient who's still in the ward as we speak. But now she's postpartum. She's a 31-year-old, EN. She's para 7 + 0. Now she's para 8 now. She was admitted as a referral 6 weeks ago. At 36 weeks, due to a low HB on screening at her peripheral, at the peripheral facility. This was detected during her second ANC visit. Her first ANC visit had been at 28 weeks. PALA was noted at that time, as it was documented in her note, in her ANC booklet, but a check HB, though was requested, was not done. However, IFAS was given. She was not compliant. She was very free with the information. She was not compliant. She came in complaining of easy fatigability, headaches, and palpitations. On examination, she was quite pale. She had mild pedal edema, no jaundice. The vitals are within normal, except a mild tachycardia. She was febrile. The CVS, interestingly, was unremarkable. Respiratory system was unremarkable per abdomen. The fundal height was at 2 weeks. The fetal height was had irregular. As for the obstetric history, she's a woman who's had quite an extensive obstetric career. Her first delivery was in 2009. Just as indicated, she had 2009, 2010, 2011, 2013, 2016. All of them were home deliveries. She said she attended at least she tried to attend at least one ANC clinic on each. She was not taking any iron on that. So we did not know the birth weight. She didn't know the birth weight. She didn't know much about the pregnancies. Even the years was difficult to come to. Of all those, only one has passed on. The others are alive and well. In 2017, she had a hospital delivery due to transverse line, emergency cesarean section due to transverse line. That baby had a weight of 2.4 kilograms. She says it was a term baby. That time she had attended one ANC visit. In 2019, she had a home delivery again. We don't know the weight of that baby. She also attended one ANC visit during that pregnancy. She was taking, she took IFAS on and on, as she said. In terms of the gynae history, she has, menarche was at 16, she had regular menses, normal flow 3 to 4 days. Contraception, she used Depo on and off. There's no history of cervical cancer screening. From family social wise, she's married to a casual laborer. She's a small scale farmer, no smoking or alcohol. In terms of the nutritional history, she reports food avoidance due to heartburn in this pregnancy. She was avoiding the green leafy vegetables, which she said were irritating her stomach and causing her gastritis, epigastric pains. She was also avoiding the legumes, the beans, the lentils, the dengu. She was avoiding all that. She preferred the bland foods, ugali and rice with tea. Once in a while, she would try some chapati, but essentially she was just avoiding food throughout the pregnancy. In terms of getting animal products, meat or eggs, due to the low socioeconomic status, she reports she had not had meat. Maybe she had meat once a month or less. On an investigation-wise, we did a full hemogram. Of course, it was a microcytic hypochromic anemia with a hematocrit of 29. Platelets was 400, WBC was normal. Stool was also normal. Her ANC profile was unremarkable. The other parameters were normal. They had not been done. We did them at the facility at 32 weeks. The ultrasound, or the obstetric ultrasound, was essentially normal. So the management is that we managed to transfuse her 5 units of packed red cells. We gave her IFAS, we dewormed, we made a birth plan, and of course, nutritional counseling. So for this client, the update is that we did deliver her. Is it yesterday? Dr. Njiro is here. We delivered her yesterday. Interestingly, patients don't read textbooks. Her baby was macrosomic, 4 kilograms, no PPH, she was fine. She's now resting well. Her current HB is 11, and she's now tolerating her hematinics and have consented to a BTL. So as we take into that account the short lecture today, what are the risk factors for this patient that are so easily identifiable for iron deficiency anemia? Yes, anyone?
Diet.
Of course, diet.
And unavailable, poor economic status, the socioeconomic status of the patient.
Yeah.
The close deliveries. The failure. Yes.
What else?
Multiparity.
Yeah, grand multiparity. Yeah.
She wasn't taking, okay, because she's attending clinic once, maybe she's not getting enough IVAS.
She wasn't, yeah.
Home deliveries, where we don't know whether she was bleeding much at home.
Yeah, we don't know about the PPH, we don't know about her status. What else for this particular patient?
Diet also.
Diet was
diet was bad.
Yes, her diet was poor. As we discussed, of course, she's a patient who's had back-to-back deliveries, and she's not very keen on coming to the hospital. And I think part of it was she felt she was being judged for having too many children too fast. But one thing that was keen to us is that nobody had taken her through how to eat properly. It was almost news to her that she should be taking her vegetables. And in terms of folic acid, I told you she was preferring milky tea, so she was doing her IFAS when she wanted with milky tea, meaning even the bioavailability of the iron was decreased. So even as much as we say the patient, she has risk factors, we expect, we can also do our part to encourage each and every patient that we come across on the correct methods of or techniques of dietary counseling. Any other risk factors? I think I had listed.
Maybe one more.
Sorry?
You noted that she had a history of heartburn. Might she also have been on antacids that she was also taking for the short period that she was taking IFAS? She was taking along with the IFAS.
Yeah, the PPI. She was on she was on omeprazole. Any other ones? Okay. I think we are we are coming to the end of our chat, unless there's an addition or subtraction from the other members in the group.
Okay. I would ask for this patient who came in at 32 weeks, was delivery imminent or not? Was she like having signs of preterm labor or not? And in an ideal setup where you have choices, would this client have been an ideal candidate for IV ion therapy, given that she was also not in cardiac failure at 32 weeks of gestation? Would that have been an option?
Yes, for her, it would have been an option. In fact, we considered that. What we had trouble with was affordability, because it was not available in the hospital and the patient was not able to purchase it. So it was just easier to correct her anemia, knowing, because this is a patient, of course, you notice that she had delivered at home, even after the previous scar. We were worried that we are going to send her home and we will not see her again. So we were targeting a HB of 10 before discharge. But she would definitely have benefited from IV ion. It's just the availability that was the issue. Any more questions? Oh, so we understood the topic. We are ready. We are ready to go and treat anemia in pregnancy. Okay.
Okay, so if we have no further questions, or are we closing out anyone? Any question, any contribution, addition, subtraction? Maybe now that we have a bit more time left, if anyone had questions from our previous sessions as well, maybe we can also take a few.
Or any cases that you are experiencing and want some answers from our experts.
Seems everybody is comfortable.
Okay, then we call it an evening. Thank you everyone for coming for this session, and thank you, Dr. NJOROGE, for taking us through the topic very well. It was very short and informative. Maybe Enoch, do you have any announcements?
Just that we have our session tomorrow, on Monday, on hypertensive disease during pregnancy. So this will be our next session, and we're going to have it on Monday evening, same time, 7:30. So come ready to learn some more. And if you have any case presentations that you want to present and ask during that period, please get in touch with me and we can arrange on how you can present that. Yeah, thank you.
Thank you.
Okay,
right.
Thank you, everyone.
Thank you, everyone, and see you soon.
Thank you.